So this talk today is the introduction to pediatric neurosurgery. I'm Shaun Rodgers. I'm one of the pediatric neurosurgeons here at Cohen Children's Hospital. I'm also the director of pediatric surgical epilepsy. I've been here now 5 years. I think you've had a bunch of talks from some of our other faculty. I have no disclosures. I just ask you guys, please don't reproduce any of this stuff. These are a lot of my patients. I had started off at Georgetown for medical school. I then went to NYU for a residency and then Lurie Children's Hospital for my pediatric fellowship. I also trained at Bellevue as the chief resident, where a lot of this stuff I think was honed in. That is my quick background. I'm now part of Cohen Children's Hospital, which is part of Northwell Health, huge 26 hospital system. And I clicked on the other one for tomorrow. Here we go. You guys seeing that?
Yep.
Excellent. So background again, Cohen Children's Hospital. This is a huge hospital system with tons of outpatient facilities, really feeding down to some of the few major tertiary hospitals. I cover over at Lenox Hill. I'm a lot of times in the NICU. Cohen's is where we do most of our operations for the under 18 category. And then I'm also at LIJ in North Shore. These are the main hospitals that I usually am popping around. This lecture actually goes back a long way. So I first met actually Dr. Bookfar when I was a medical student, rotating with him at Cornell way back in 2006. And then Randy rotated with me while he was a medical student way back in 2013. So I think this lecture really comes full circle and a long history, I think, of teaching and what you see a lot of people coming together really to teach. So I'm really thankful.
Did you get that picture
here.
Is it a GQ picture of him? What the heck is that?
That's his Twitter handle. I'm pretty sure that's Twitter.
Jesus Christ.
The skull in the background really makes it.
Yeah, love it.
So what is pediatric neurosurgery? And like all other things, I think where you look first is Wikipedia. Pediatric neurosurgery is subspecialty neurosurgery, so it really doesn't help. It's really defining it by one of the words inside of it. But really, it takes on the surgical procedures of the nervous system, the brain, the spinal cord, the spinal column in children. And the way we usually break it up is a lot of that stuff is 18 and under. It does pose some of the unique stuff, though, to kids that isn't present in adults. But I'd also say a lot of the procedures that we do is sort of general neurosurgery. And one of probably the last facets of being able to stay within general neurosurgery. We always have to, I think, look back on where we really came from. And probably the first person, 1929, Frank Ingram, is probably who we would say is the start off of pediatric neurosurgery. He was a Harvey Cushing protege. He established the first pediatric neurosurgical unit at Boston Children's Hospital and really dedicated his career to the care of children. I'm sure Harvey Cushing has come up in multiple lectures, really the grandfather of all neurosurgery. But Ingram really was the pioneer and leader of pediatric neurosurgery. And really it was his imagination, his intelligence, his ability to lead and inspire others. Cushing had been regarded as the founder of all neurosurgery, and it's very fair that Ingram and then his disciple, really Donald Mattson, really put on most of the early writings and early teachings in pediatric neurosurgery. So if you step back, looking at the forest from the trees, there's about 50,000 neurosurgeons in the entire world. There's about 2,300 pediatric neurosurgeons in the world. In the United States, it's only about 300, just under 300. And I'm going to try to break this up into about 10 big topics because clearly this is a 1,000-page book. Could be a huge topic, and I think we're going to really run through this over the course of about 10 different disciplines within pediatric neurosurgery. Our big journals are Child Nervous System, Journal of Pediatric Neurosurgeons. Those are the two international and the American version, essentially, of our big journals, and really I think where this gets broken down into. And really, it's what's piqued my interest in neurosurgery. I was learning everything, and there wasn't really an operation that I didn't like. And I really enjoyed seeing every aspect of the person. I really enjoyed working with the kids, and being able to do all different types of surgery, not doing the same one every single day, really piqued my interest. You can see we deal with tumors, spinal fusions, epilepsy surgery, it really has a varied aspect all throughout the entire body. The pediatric brain and spinal cord stuff, I'm going to try to leave a lot of that till tomorrow. We were going to talk a lot about tumors tomorrow, but really, usually the main part of this is trying to take the tumor out and trying to take the tumor out safely. Just like you've been hearing probably in a lot of the adult lectures, you're trying to get the problem area into the bucket and you're trying to have it never come back. And that usually, for the children, can require chemotherapy, and some of the older children, radiation therapy. Some of the stuff that I specialize in would be endoscopic endonasal surgery for some of the craniopharyngiomas. This is one of our recent works, and really taking out some of these, especially pediatric tumors through the nose, that people really were trying to say wasn't able to be done in children. Some of the tumors that we take out, though, we can't always take out, and all we can do is biopsy. One of the things I'm sure you guys have heard about, read about, and lectured about was biopsying midline gliomas. Midline gliomas is one of probably the most horrific diseases of childhood. It usually happens from probably around 3 years to 10 years old. There is no cure for it. It is 100% fatal at this point. And we really are trying to pioneer some of the robotic technology into biopsying these and really provide more pathology to actually move forward in this field. One of the things I also specialize in, I think, is pediatric epilepsy. I'm the director of the pediatric surgical epilepsy portion for the neurosurgery side. This, though, deals with a lot of the neurologists as well, and they really have to work up these patients to bring them to the surgical epilepsy world. We here are very fortunate. We use really cutting-edge technology. We have a ROSA robot that's able to place electrodes and fibers into almost every area of the brain. We also have laser fibers that we're able to burn very, very specific areas of the brain in order to hopefully cure epilepsy, or at least to lower its burden on a child. And epilepsy is a huge burden. US incidence is about 150,000 per year. 1 in 26 people will develop epilepsy at some point in their life. 1.3 million to about 2.3 million is the prevalence. And it's about 45,000 American children under the age of 15 per year develop epilepsy. This is 20 to 25% of epilepsy then goes beyond the medically refractory into the surgical world. It's great if we can just give them a pill, they stops their seizures and they get to go on with their life, but about 20 to 25% really do not. Here we've had quite a bit of press, quite a bit of really groundbreaking surgery done at the Children's Hospital. We really have taken it to the next level, using every aspect of technology to really provide some of the best care. We're using cameras to go into brain to take out epileptic zones. We're able to use lasers to burn areas of the brain, and then we're actually using a robot to really pinpoint exactly where these seizures are coming from. This is one of our planning things. This is what we call an SEEG, a stereo EEG, is where we put depth electrodes into the brain, and really those depth electrodes are going to monitor the patient over a course of about a week in order to tell where the seizures are coming from. You can see here, this is our planning trajectory. Hopefully this video is playing for you guys. You can see every one of these colored fibers is actually going to be an electrode that goes into the brain. This one needed bilateral because the disease was so prevalent throughout the brain, and we really needed to pinpoint where were the majority of the seizures coming from. You can see in the video, we plan out here on a 3D model, but really this requires a ton of planning ahead of time to get these very accurate. You can imagine placing an electrode into the brain. You have to avoid the veins, the arteries. You can actually place these into really critical structures so you know, is the seizures actually coming from the motor strip where the motor function is? Is it coming from the language area? And we know we can't resect that area. This is really, really high level planning that goes into these, but really gets the pinpoint, and I think very accurately describe exactly where everything, the seizure activity is coming from. This is going to be a live video of the robot actually in action. So the robot is connected to the head. All those pre-planned out trajectories have been studied, making sure that they're going to be very safe. The robot is then registered to the face. So it's sort of like a 3D representation of the preoperative MRI and CT scan.
Is this a Netflix patient?
You can see here, after we're registering the face,
She's 38. She was used at 10.
you can also see then the robotic arm has haptic feedback, and we're actually able to move the arm in place. The way I like to describe it is essentially it's the bow and arrow. The robot is the bow, and you're pulling back the arrow and able to put the lead into the correct spot. The robot is not doing the surgery for you, though. By any means, it's still your hands, it's still your drill, it's still your placement of the electrodes. We are double checking this at every point. You can see here the planned out trajectories into the temporal lobe. And this really lets us do a very accurate, really precise surgery into very critical structures. You can imagine if you are off just by a few millimeters, you're placing one of these electrodes into the brainstem, into the optic nerve, even into the carotid artery. The majority of this is extremely safe. We've done over 300 leads at this point. We haven't had a single, knock on wood, bleed. We haven't had an infection. So with enough planning ahead of time and making sure that every box is checked, you can make this extremely safe surgery. Using that technology as well, you can take it one step further. So you pinpoint where the lesion, the seizure foci is coming from. You actually can take then a laser fiber if it's small enough, and you can burn away that lesion. You can take a biopsy, you can burn. You can see here, this is a laser fiber coming into the brain under MRI guidance. So these heat maps are produced under MRI, during the MRI, and under direct vision, we're able to make a burning zone, essentially, a destruction zone that's going to be destroyed. And we know, based on multiple animal models, that this is going to be a sort of death area where the cells that are causing the seizures are going to die. This is a hypothalamic hamartoma that you can see our laser fiber going into. You can see then the patients in the MRI. You can see us watching the MRI directly, and then these color maps are producing heat sources, and we can monitor 6 different heat sources. We can pick points with low thresholds so that we know the optic nerve should never come over a certain temperature so it's not damaged. We can put temperature sensors right near the fiber to make sure it doesn't get too hot and actually vaporize the tissue. All we want is the tissue in that area to die and the seizures to stop. So you can see we're doing this under direct vision. The MRI is running the entire time. We're burning and watching the heating up. Once we reach a certain degree Celsius, that tissue we know will die. And we can make this very, very accurate. We can actually pull the fiber back even as we're doing it, or push it in further to make it a little bit bigger. But this is usually spared for very small lesions and very delicate, really precise parts that you want to take out without it actually affecting any other area of the brain. When we can't take something out, so in epilepsy, really the gold standard is to take the foci out, take the part of the brain that's seizing, causing the abnormal electrical activity out. Instead, now we have a device called a NeuroPace, and on this NeuroPace device, it's a responsive neurostimulator. We can actually put electrodes, you can see on this lateral skull X-ray, these are electrodes that are going into the brain, and those electrodes actually are going to sense for a seizure. They're running what we call an EEG continuously. Once it sees what looks to be like a seizure, it can send an impulse, and that impulse can go down either lead. It can actually come from the generator, the battery pack essentially, and it's going to stop it. We do this already for the heart for the last 50 years. If we see an arrhythmia in the heart, that's an abnormal rhythm, we actually have things called ICDs that shock the heart and actually stops that abnormal rhythm and makes the heart beat in a normal rhythm. We're taking sort of that kind of technology one step further, where we're actually reading the EEG in this specific location. We're watching for abnormal electrical activity, and once we think we see a seizure, we're actually impulsing electrical charge to stop those neurons from firing, sort of resetting those neurons so that then they sort of tick in their normal ticking manner rather than taking it into a seizure that sort of spreads over the entire brain. We're able to do this for the first child on Long Island. We were able to take in the robot. We were able to find out where the seizures are coming from. Then we placed a neurostimulator in this spot, And we're able to take a young boy who is having 20 seizures a day, and then even some subclinical seizures that they weren't even aware of, to having no more clinical seizures and only having a few subclinical seizures at night. This is a really, in locations of the brain that you cannot take out, with causing a major deficit. We're talking about losing your speech, losing your motor function. This has been a really big advance for us. It's been such a big advance that people like Tesla want to take this to a brain interface where they're actually adding stuff to people that don't even have problems. That's sort of the science fiction, sort of the 20 to 30 years into the future, but it is a pretty amazing device that we can offer our children now. We're going to move on to the third topic, pediatric neurosurgical trauma. I think this is one of the huge things that we see in pediatrics. Usually one of the highest causes of death, morbidity of children under the age of 18 is actually trauma. Clearly risk-taking is a problem, but really any trauma in active individuals can really be a burden. We deal with a lot of spine trauma in children. We can have fractures, we can have ligamentous disruptions. Here you can see on the left, a screw placed into the C2, C1 joint. You can see then an occipital plate. You can see that in the intraoperative picture here. This is for a major fracture dislocation that happened during a trauma. You can see bone graft that we've placed along the rods and the screws. What you see here in pediatric neurosurgery is sort of a totally different direction. We were just talking about lasers, we were talking about SEGs, we were trauma. We also have things that you've learned about in your other lectures, like subdurals, epidurals. We have a lot of trauma in pediatric patients, and I think it's sort of what keeps pediatric neurosurgery exciting. You have traumas coming in, you're doing also very intricate surgeries, and really what made it appealing to me. We also have this as a skull fracture. You can see here in the top right corner, a comminuted skull fracture. You can see the incision that we were using. We use these wavy incisions on the kids so that the hair grows back in a crisscrossing pattern so you never see the incision. You can see a little brain contusion underneath, something that though does not need an operation, but the skull fracture needs to be fixed. You can see here the intraoperative of the pieces. We're really putting Humpty Dumpty back together. We're taking these pieces and plating them together. We have, for the really young children, absorbable plates that actually dissolve with time. And for the older children, we have titanium plates that sort of seal everything there and then let the bone heal back together. It's some of the most rewarding things that we do, is to take a child that's coming to you in a trauma that is near death and being able to return them back to their family. It is a privilege, just a wonderful gift to be able to do this for families. And really what makes my job one of the most rewarding things, and there is never a day that I don't want to come to work, because it really has a reward that's so much beyond everything else. We have, unfortunately though, some traumas that are just not survivable. And dealing, like you've seen in some of your lectures, dealing with death, dealing with bad news. You can see here a bullet to the spinal cord that has paralyzed this child, and the bullet is lodged within the spinal canal. You see this is self-inflicted suicide, where there is no hope for survival for this. This is really devastating, and this is where being not just a surgeon, being also a doctor, really comes into play. We're then going to switch to another topic, pediatric skull deformities. I think this is one of the huge things that we see in the office, and what many of the parents in the audience will actually come to see as well. One of the #1 things I see in the office is what we call deformational plagiocephaly. This is essentially just from the child sleeping on the back of their head too much, and you see a malformed skull. The reason we see them so much, though, is we're trying to rule out other aspects that can be very damaging to the skull that need to be fixed early. These sutures that I'm sure some have been over in the lectures, the coronal suture, the sagittal suture, and the metopic suture, as well as the lambdoid sutures in the back. This is the front of the head. This is the back of the head. This is the normal anterior fontanelle that usually closes about around the 1 year of life. These sutures, though, also close eventually. The metopic usually closes first. The sagittal, coronals, and lambdoids really stay open until later in life. They, however, can close prematurely. You can see here in the upper left-hand where we have a sagittal synostosis. The sagittal suture has closed early, and because the head, the skull, cannot grow in different directions, you only can grow forward and back because the lambdoid suture and the coronal suture is open. It gives you this very long scaphocephaly, or like a boat bottom shape. Another one of these is called the metopic synostosis, the metopic suture, which is in the forehead, and you can actually feel it on yourself. This can close too early in the first few weeks to months of life, and you can get a very pointed head called trigonencephaly. The head can't grow forward and only can grow out laterally to the sides. We then also have bilateral coronal, where the coronal sutures both close, and we have a very broad-based, surprise-looking head. We also have unilateral coronal synostosis, where one side just closes, and we have sort of a one eye up surprise look. The most rare of all these is lambdoid synostosis. Lambdoid synostosis is when one of the back sutures, and really that causes a ear up and down problem. You can see here, this is one of the sagittal synostosis. You can see sort of a peanut-shaped head, and you can see how the suture is closed. You see a major ridge along the suture. The lambdoid sutures are still open. You have this occipital bun here in the back. And you see on the forehead becomes very bossed-like. We call that frontal bossing. You get a very prominent big forehead. In order to fix this, we can do this endoscopically now at the first few weeks to months of life, usually with under 4 months. And we can take away that strip. We can take away that entire strip in order to help reshape the head with a helmet. Sometimes we have to wait till about 9 months, and we have to do a much bigger open procedure. Occasionally, children are not even found until much later in life, and then we have to do a much more extensive procedure. Here you can see this is the front of the head. This is the bottom of the head. You can see here we're taking away the hashing of the sagittal ridge suture. We're then going to barrel stave. That's these cuts here in the middle frame. We're going to expand, right? The skull couldn't grow out laterally, so we're going to expand out the brain and the skull laterally. And this was a much older case, so we actually had to use these absorbable clear plating system to put some of the chips back. Otherwise, there would be some skull defects. In the very young ones, we can take away this whole entire hash mark, and that skull will just grow back. And that really is because the kids are so young. You can see here in the far right slot, really all those plating system, and you can see our wavy incision. This can be very rewarding. You have a very dysmorphic child, and then you see them 6 months later, and they look just like everyone else. Their incision has healed perfectly. All their hair has grown back, and they're going to go on to a life sort of that is totally normal for them. This one thing to be noted is there is nothing wrong with the brain here. This is truly a suture skull problem. There is nothing wrong with the brain underneath, and really needs to just be more of a cosmetic procedure. Here's one of our coronal synostosis. This is a unilateral left coronal synostosis. You can see here this child, the eye looks very surprised, looks pulled up. You can then see in our video here, this suture, the coronal suture, has been closed. You can see this coronal suture closed. This brings the eye up, and we have to correct that by actually taking the entire brim of the eyes off, the frontal part of the frontal bone off, and reforming that. These are done in conjunction with our craniofacial plastic surgeons. This is a metopic suture. So the metopic suture is the one on your forehead, usually closes around 9 months of life. You can see it creates a very pointed forehead and very pinched in eyes. Our goal here, you can see the pointed forehead, is to actually expand the eyes and take away this ridge and really round out the head. How we do that is we remove the entire frontal bone. You can see here the fontanelle, the anterior fontanelle that's been taken out. All the dura, the covering of the brain, the entire brain is untouched here. We then also take off the orbital rims called the bandeau. This is where the eyes would sit, just under the orbital rim. And we replate it by expanding the forehead and expanding this orbital bandeau in order to prevent what we call hypotelorism. Your eyes get pushed in when you have a metopic synostosis, and we want to pull them out. Switching from the less cosmetic, this is what we call a dermoid lesion. Children can be born with trapped skin cells that are trapped inside the bone, and they actually grow with the child. Some of them don't grow and they can just stay there, but most of them do end up growing quite large if you let them go a few years. This is one in the occipital region. You can see here, this is a CT scan. This is the eyeball in the front. This is the back of the skull, the back of the neck, and this is a lesion that's in the skull. That lesion is actually trapped skin cells, dermal layer, and that needs to be cut out. Otherwise, it's going to keep growing and actually can invade through the skull. This is a quite large one. Usually we take these out at sub-centimeter level. You can see here us dissecting it off. This one did not penetrate the skull, and we just have to get it off of the skull with leaving no remnant behind, because if you leave a remnant, they actually can grow back. You can see the crater that was left in the skull. This is a much older child with a much more dramatic dermoid. Most of these are very tiny. They're taken out as a baby, and they'll never grow back. You can see here we're working a plane around it, keeping the entire capsule intact, not rupturing any portion of this dermoid. If we rupture it, we really have to follow it much closer because some of those cells can actually grow back. These are usually same-day procedures where the child goes home the same day, and usually they're curative. Flipping to the next topic, congenital brain abnormalities. I think one of the biggest things with the congenital brain abnormalities is probably the Chiari. Chiari malformations are an extra amount of cerebellum in the back, or a very tight posterior fossa causing the cerebellum to get pinched. The cerebellum is the back part of the brain, probably one of the oldest structures we have in our brain, as well as our brain stem. This allows us to do a lot of our movement and fine-tune our movement. However, occasionally we are born where our back of our skull, or we have too much cerebellum, and that can get pinched and prevent the fluid from flowing around. This in turn can cause what we call syrinx, or holes in the spinal cord that are filled with fluid. You can see down here a significant cervical syrinx. One of the biggest series that's been published is a series that we put out recently on the Chiari 1 malformation. Now, we used to traditionally only do this one way, by removing the bone in the back, opening the covering of the brain, and actually shrinking these tonsils. Now, in certain cases, you can offer just the bone removal and then stripping of some of the ligaments in the back. This will allow the dura to expand and actually let the flow go around the cerebellum. And this can sometimes decrease the complication rate of that surgery. We also remove the lamina of C1 in order to give more room for the Chiari malformation. This then will allow the fluid to go around the cerebellum. It will usually cause the syrinx to resolve. And most of these children are presenting with severe headaches, severe posterior headaches. Occasionally you can have a cape distribution of numbness and tingling in your hands coming down from your shoulders. But usually the number one symptom is headache in a lot of these children. This can also happen in adults and sort of can be treated in the similar fashion. I'd be remiss if we didn't cover hydrocephalus. Hydrocephalus is probably one of the biggest problems in pediatric neurosurgery. Hydrocephalus essentially build up a CSF inside the cavities of the brain, the ventricular wall. The ventricular system is actually what holds the CSF, as well as the subarachnoid space. This may cause then an increase in pressure and cause a lot of the symptoms. Usually a production of CSF per day equals about the resorption of CSF, And we're really in this happy homeostasis balance. You're producing CSF, you're absorbing CSF, and you're really happy. Your brain is getting bathed in all the ions that it needs. It's really protecting and cushioning your brain to do all the jumping, the running, the falling. However, problems occur when that balance is thrown off. And there's really three main types of hydrocephalus. And a lot of this is presented early on in life. One is called non-communicating or blockage. This can be caused by tumors, can be caused by scarring of the arachnoid. And essentially it's a blockage. It's essentially a clog in your drain. You're not able to have fluid go around. It builds up in one area, not in another area, and you have to fix that blockage. The second type is called communicating. This is much more an absorptive problem. This can happen during infection or bleeds or even tumor because of the tumor spread or tumor protein burden within the CSF. There's a third type that we really won't talk about called normal pressure hydrocephalus. That's much later in life, and that's usually with a normal pressure but large ventricles. When you have a child, usually you're dealing with non-communicating and communicating hydrocephalus. You might want to say that in Chiari's, Chiari type 2s, you can have a totally different type of hydrocephalus. That's something that we're not going to cover here. So you're really trying to figure out, is it communicating, is it non-communicating, and how can I fix it? This is the classic presentation of a newborn that's born with hydrocephalus. You have an absorptive problem, either from bleeding or infection or a blockage, and you can see here the skull gets enormous. Those sutures that we talked about earlier, the metopic suture, the coronal suture, the sagittal suture, and the anterior fontanelle, those expand, and they just keep expanding and expanding, and it's sort of like a basketball that's being overinflated. This water is building up, causing pressure on the brain, causing neurological problems. One of the main things is the eyes usually can't work. Usually you have a 6th nerve palsy, a up gaze palsy, and we really have to identify this. These are very large heads, and we have to deal with the water that's building up. So how do we deal with that water? Traditionally, we've released that water into a sort of a plumbing system. We place a catheter into these large ventricles that have lots of brain fluid, CSF, and that's drained then into another cavity. And that cavity then will resorb the fluid, unlike the problem where the fluid is not getting reabsorbed or getting blocked. We're essentially plumbers in this aspect. We're trying to fix the clog, or we're trying to have a different part of the body absorb. We're building a separate tank, essentially, that's going to absorb the fluid. We use this silastic tubing, this very nice tubing into the ventricle. We then have valves that are able to regulate the pressure, the flow, and then we have more tubing to sort of direct it. We have very fancy valves that we use here in the United States and a lot of the really developed countries that are able to adjust the pressure, regulate the pressure over time, and change if we need to without having another operation. But traditionally the valves had one setting, and sort of the children just lived with that one setting. So we place a catheter into the brain. We then place that catheter into the valve, and then the catheter runs down into 3 different main locations. There's a few others that we're not going to talk about here, but the 3 main locations, or the covering of the abdomen, all the tubing is running under the skin. The second one would be a VA shunt, or into the ventricular system, and it's really into the right atrium. And then the last one is a V pleural, or ventricular pleural shunt, where it actually goes into the pleural cavity. What you're asking this to do is you're essentially wanting surface area of the peritoneum, surface area of the pleural space, or the blood volume to be able to absorb fluid. If you think about it, an adult or a child can produce anywhere from about 500 cc's of CSF. So you're talking a 500 cc volume that you need the body to somehow absorb into itself. If you put this into a very small cavity, you essentially wouldn't be able to absorb that amount of fluid. And we found over time that the peritoneum, the heart, and the lung are the 3 best. The least problems with any of these systems is clearly the peritoneum. If the peritoneum is clean, is able to absorb fluid, that is the ideal location. And then depending if that is not an ideal location, we decide if the heart is a better location or if it's the lung. We have another way, though, of treating hydrocephalus when it's blocked, and that way is called a third ventriculostomy. So sometimes you can have what's called aqueductal stenosis. You can have a blockage here at the aqueductus sylvius. This is the midbrain, and this is the tectum. This is the cerebellum in the back. You can see here very, very big, what we call lateral ventricles, an expanded third ventricle, expanded pineal recess. But the fourth ventricle here is normal size. So the blockage is here at the aqueduct. So how could we get around the aqueduct without placing a catheter into the ventricle and having a shunt? How can we artificially go around this blockage? And with time, we've developed what's called an endoscopic third ventriculostomy. And that's when we put a tube, a hole into this area, into what we call the prepontine cistern. This is the pons. This is the prepontine cistern. And at the floor of the third ventricle, we're going to create a hole. And we're going to create a hole so that the fluid can go around the fourth ventricle and sort of bypass it. This works and has success in different aspects. It's not perfect for everyone, but here you can see we're taking a camera down into the ventricular system. This is on the right side. You can see the choroid plexus that people probably talked about. This is the red fronds that are looking here. This is a septum pellucidum that's been really torn away with hydrocephalus, really shredded because of high pressure. That's almost gone. And you can actually see the other side of the ventricle. Hidden behind here would be the other side's foramen Monroe. This is the foramen Monroe. This is one of the main passageways of CSF in the brain. Surrounding that is the fornix. As we dive down deeper, we're going to go through the foramen Monroe, following the choroid plexus, and we're going to be staring then into the third ventricle. The third ventricle of the brain has the floor of the third ventricle here. You then have the basilar artery beating at the bottom. You have the mammillary bodies. You have bilateral mammillary bodies. You then have an infundibular recess, and you have an optic recess. As we travel down into the third ventricle, we're going to be able to make a hole to bypass the blocked aqueduct. You can see here the beating. This is a balloon, a Fogarty balloon, and we're trying to create a hole that goes down. This is a grasper to expand that hole. You can see then those white adhesions beyond the hole. That's actually arachnoid that we have to make sure we go through, because that can scar over and block our endoscopic third ventriculostomy. You can see us expanding that hole, and now you can see the puff of CSF going through that hole. You can see that hole is able to bypass the entire aqueduct and is able to cure this hydrocephalus. Once again, you see the mammillary bodies at the bottom, you see the basilar artery, and really a great alternative to curing hydrocephalus than putting a shunt in. We're going to then go on to the next topic, spina bifida. Spina bifida comes in many, many different forms. This is the most severe form. This is the open neural tube defect. So this is actually a baby that's born. You hear about this in the news with folate for mothers. This is an open spinal cord defect. You can see here at the bottom, this is actually the central canal of the spinal cord. This is what we call the placode. And this is a filleted open end of the spinal cord. Babies that are born like this need to be closed. Otherwise, they will get meningitis, they will get hydrocephalus, and they will have major, major complications if it's not closed. Sometimes you can do this in utero. In select cases, you can actually do this while the child is still in utero, in the uterus. We're not going to talk about that here because it gets very complicated of where and when and how that can be done. But if a baby is born like this, we can cut away the dead skin that's around the side. We can close the spinal canal, the neural tube. We then close the dura and we close the muscle and the fascial layer in order to get a nice closure. This is glue over that closure in order for this child to hopefully have a fairly normal life. They come in all shapes and sizes. You can see this is a placode that's really buttoning up because of hydrocephalus. You can see the excess skin around the sides. You can see again the placode here. You can see the central canal of the spinal cord at the top. And sometimes babies are born with very minor deficits. Moving of the toe, moving of the foot is a problem. However, sometimes these can be major deficits. And in this case, you can see this child cannot move their legs. This is major leg deformities because the muscles in the glutes, the thighs, the calves are all very, very abnormal. You can see here a twisted foot, and this baby is unable to move. This is a lifelong disability. Wheelchair bound, not walking. However, closing this, the baby's brain, the rest of the arm function is sometimes unaffected, and you can have a very, very good quality of life. This is obviously our goal, is to get a nice closure. You can get a very, very nice closure where you can prevent any infection from coming in. You can actually recreate the CSF pathways at the bottom. A lot of complications later on down the road, but things that we're actually able to deal with. Sometimes you actually have spina bifida where the skin is actually fully covered. The plaque code is actually, the spinal cord is still within inside, but you have a big, what we call myelomeningocele. And this is really the expansion of the dura, expansion of the skin filled with CSF. And you need to take this because this also can break down. This is also can cause problems. You can see here in this video, we're actually transilluminating, taking a flashlight and transilluminating, showing there's really nothing in here except fluid. You can see here in the right corner, these fascial planes that we're able to develop, and this really bubble of CSF that we actually have to repair the covering or the dura that's in the spinal canal. We have a few more minutes, so hopefully we can get through a few more. Pediatric scoliosis is another thing that a lot of pediatric neurosurgeons do in combination with orthopedics or spine surgeons. This is a vertebral body that's essentially a hemivertebrae that can be fixed with rods and screws. This can have a lifetime deformity. However, if you fix it early enough, once they're skeletally mature, you can really prevent a lot of the long-term problems with kyphoscoliosis. Some of the new technology that we're doing is tethering and also magic rods. And these rods are essentially growth rods. And we can't fuse people early on in life because they'll have poor lung function. We put temporary rods that actually allow growth but stabilize a scoliosis. This is really some of the cutting edge technology with tethering and growth rods. We also do vascular malformations. We have cavernomas here you can see on the left. You can see AVMs that we work with our endovascular colleagues to embolize and take out. These can be the cause of bleeds or seizures in pediatric populations. We also do nerve surgery, essentially brachial plexus surgery, nerve tumor surgery. You can see here planning out a brachial plexus repair. You can see a big neuroma, and you can see us really tagging a lot of the nerve roots. And in the brachial plexus, we actually can transpose portions of the nerve root in order to gain some function back in brachial plexus problems. This is the classic Erb's palsy that you're going to see in this video with a trunk injury. You can see the hand turned in, facing down. You can see this is, babies are born a lot of times with a shoulder dystocia. Number one risk factor for that is maternal diabetes. And can have a devastating lifelong effect. But if you can return some of the function, it really can help them really have a higher quality of life. You can see the classic turning down. I think we got through the 10 topics. A few of the other things, though, I think that are really important, and especially big, I think, in pediatric neurosurgery, is resident education, teaching medical students. I am a huge proponent of that. You can see we have a huge department of neurosurgery. We could run cadaver labs. I run lectures. We run a lot of the helping international and our own residents get fellowships. I think a huge portion of medicine in general is really passing it down the road, and really you're helping everyone get to where you are, because if you're teaching someone, you're really learning at the same time. I think that is a huge portion of what I do. And also for pediatrics, we also do a lot of community outreach, especially with hydrocephalus, brain tumors. Really, there is a huge community outreach portion of this that sometimes is a little bit missed. Hopefully we made it through 10 of the big topics. Like I said, this is 1,000-page books that are written on these topics, and hopefully you guys got a little bit of a flavor for pediatric neurosurgery. I want to thank you guys for having me today. Really amazing stuff that we're able to really switch to an online platform to share with, I think, a lot of people. And then also in honor of Dr. DeMarco, We will also added a little pediatric ink to our lives here at the Children's Hospital, temporary pediatric ink. Hopefully he approves. Thank you guys for having me.
Thank you so much. I'm going to open up the chat now if you want to take a few questions in the last few minutes.
Sure.
You could turn off screen sharing if you want. And then...
Okay. So stop sharing.
Can you see the chat?
Here, pulling it up. There we go. They're flying by.
Yeah, we got 600 people here right now.
What made you interested in treating pediatric patients versus older patients? I saw that fly by. I loved working with the children. I did not mind dealing with parents. I really felt that it really let me do a bunch of different surgeries and not getting locked into just one type of surgery. I really enjoyed the variety. We also, what advice would you give? Oh, man, that runs fast. Do children,
if you
scroll up?
It will stop refreshing it if you scroll.
Oh, okay. Where are we? That was the last lecture. For the dermal removal, would you repair the dent left in the skull? Yes, sometimes we repair the skull so there's no deformity. We would shave down the bone. What causes the skull sutures to form early? That's really the genetics of that are really fibroblastic growth factor. We're really trying to figure out the genetics, what is actually causing. We're actually taking sutures and we're actually trying to sequence genes in normal sutures, not normal sutures, and trying to figure out what actually is causing that and if we can predict it or even prevent it from happening. What made you interested in pediatric neurosurgery? I said the variety. Do you know before the baby is born about most of these problems? Yes. A lot of times these are picked up on ultrasound during a normal anatomy scan at about 20 weeks. And then a lot of these children now are getting fetal MRI. So an MRI while the child is still in the baby, in the mother. We deal with the families and the parents, I think, exceptionally well. You have families, obviously, for adult patients, but I think it's a whole nother different aspect to that when it's a child and its parents. I have kids myself, so I think that really lends itself to really putting yourself into these parents' shoes. Do you make use of proton beam? Yes, so proton beam therapy is one of the new ways of giving radiation. It has a very fast drop-off. We use that a lot when we're trying to prevent other areas of the brain from the temporal lobes getting radiation or the esophagus from getting radiation. You want to keep the radiation in the tumor area. So we do use proton beams. Cause of pediatric brain tumors is like many other things. There's usually a genetic component, maybe a second hit hypothesis, where you have a gene that puts you at risk, something like a P53 gene. Certain types of problems such as neurofibromatosis really put you at risk for tumors. Normal neurosurgery in adults versus pediatric, I think there is a huge amount of overlap that you get to do sort of the same stuff in adults, but clearly in pediatrics, you see these diseases that you would never see in adults. They only come out. Craniosynostosis, early spina bifida really have very little overlap with the adult portion. What is the most developing field in pediatric neurosurgery? I think a lot of this, we have utero surgery now. In utero surgery, we have really new brachial plexus surgeries. We have new epilepsy surgery, new brain tumor protocols. Really, pediatric neurosurgery really is some cutting edge stuff. Not all spina bifida patients end up walking. Some of them do, some of them don't. It really depends on the level of where this is. Someone asked about hemispherectomy. Sometimes in epilepsy surgery, we actually have such extensive problems on one side of the brain, and we actually can cure the patient. I'm talking no medicines, full out cure, but there's going to be a price to pay, and that usually means some weakness on the other side. We do hemispherectomies where we actually don't remove half the brain, but we disconnect half the brain. And by disconnecting it, we cure surgeries outright sometimes. This happens in Rasmussen's, and that surgery is one of the most rewarding surgeries that I do, because by doing such a big surgery and actually giving the child a deficit that's temporary and even permanent, we actually cure surgeries. We're talking 0 seizures, and these are kids that have 100 seizures a day that have no quality of life, and you have essentially given them back to their parents. In utero surgery is done by using, it used to be an open cut into the uterus, and we used to be able to repair it just like we did normally as after the child was born. Now we use a lot of fetoscopes, where we actually place laparoscopic instruments into the uterus and do it laparoscopically. How do you treat congenital AVMs? Obviously, AVMs is a very complex topic. There's a lot of grading systems. AVMs in children, the #1 difference I would say is that they can come back, and they come back in the same area, they come back in other areas. It's something that you really, in congenital AVMs, need to follow those patients much more than any other AVM patients, because they can come back so readily. But the normal ways we treat it are embolization, resection, and sometimes you can even do radiation in children. Difference between operative trauma and non-operative trauma. So I see way more non-operative trauma, where we're putting patients in collars, getting MRIs to clear their necks, than operative trauma. Traumatic brain injury is a huge thing that I do. TBI, we have a concussion center that we work closely with neurosurgeons, neurologists, physical therapists. I do not do prenatal in utero. There's only a few places that actually do that, and because it requires such a huge team, really those resources, doing 1 or 2 surgeries in a lot of places doesn't make sense. It much better be like 10 surgeries in one center. Do we get through a lot of those?
Yep, it's 11 now though. But
Okay.
for everyone that really enjoyed this, he will be back tomorrow. Dr. Rodgers will be talking about tumors then. So thank you so much for joining us today, though.
Yeah, my pleasure. Really, thank you guys for putting this on. This is amazing work by Randy and David. Really, they really outdid themselves this summer, and it's amazing what a little social distancing can force us into.